I am starting the recording now, and this recording will be posted to the DMH website with the other minutes.
Thank you.
Okay, welcome DMH and the Adult State Program Standing Committee. This is 2020. I'm ahead of myself. 2020. We'll review the agenda per usual and then do introductions. So 12 noon to 12:20 SPSC business. We've already confirmed that the meeting is being recorded. We'll do introductions. We're reviewing the agenda. Vote on public comment participation today. Vote on August minutes. Then do the listening session, next steps, the history of committee's main tasks, current main tasks, reimbursement for member time outside of meeting membership discussion. Then we'll have a membership update, membership subcommittee process, and we'll talk about how we feel about having 3 members from one organization. 12:20 to 12:50 will be the DMH leadership update. DMH Commissioner Sarah Squirrel and General Counsel Karen Barber will be joining, and a response to the AMH SPSC letter to the commissioners. 12:50 p.m. to 1 p.m. we'll have a break. 1 p.m. to 2:30, CSAC staff attending for redesignation discussion. Joining will be Rachel Lee Cummings, Executive Director, Alexander Sandy Smith, Director of Adult Services, Dr. Bob Jimerson, Medical Director, Andrew Brown, Compliance and Quality Assurance Officer, Barbara Doyle Wilch, or I don't know how to pronounce that name, W-I-L-H. How is it? Board Vice President. 2:30 to 2:45, draft letter of recommendation to the Commissioner regarding CSAC redesignation. 2:45 to 2:55 p.m. public comment. And the last 5 minutes before 3 p.m., we will look at the October draft agenda, review aggregate grievance and appeal data, SPSC members to raise specific questions for DMH staff about G&A process. All right, is anyone on video who can call on people for introductions?
I can help do that if that's helpful. This is Eva. I just wanted to note on the agenda some things that members voted or talked about over email changing. The State Program Standing Committee business, the first order of business, having it end at 12:15 so that the DMH leadership update can go 12:15 to 1 o'clock and working through the break today.
Yeah, sounds good.
Thank you. So members of State Program Standing Committee, we just heard from Marla. Dan? Can you just introduce yourself?
Did you say my name?
Dan, yeah.
Yeah, this is Dan Toll, member of the committee.
Thank you. Malika?
Malika Puffer, she, her pronouns, peer support manager at HCRS and member of the committee.
Thank you. Ward?
Ward Nile, a member of the committee. Thanks.
Any other members of the committee? Please check in now.
This is Kate. I joined late. Sorry, member of the committee.
This is Vicki Warfield, she, her pronouns, member of the committee.
All right. Any Thelma today? All right. Members of the public, Zach, are you there?
This is Zach.
Hello?
Thank you. Yeah. Anyone else from the public on the phone today? Okay. And
Does that mean, were you just doing the phone public or were you doing video public too?
video public too. Anyone from the public? So it looks like Lynn is here.
Okay.
You want to check in for us?
Lynn Cardozo, and I'm the director for the Vermont Communication Support Project, but I am I'm soon to be an official applicant for the committee, but I will be applying as an individual with lived experience. And yeah, hi everyone.
Thank you. Anyone else from the public on the phone or on video?
Yeah, this is Frankie. I'm a peer support advocate at HCRS. Pronouns they, them. Here as a member of the public.
Thank you. All right, we'll scoot over to members of DMH.
All right, is that everybody on the phone and the video for members of the public? All right, so let's move right along, please, to the August minutes. I'll have to abstain.
Quickly, the folks on the phone from DMH, Eva Dayan, Karen Barber, Jessica Bernard, Morning Fox, Tom Weigel, Trish Singer, and Sarah Squirrel. Did I miss anyone from DMH? All right, go ahead, Marla.
Okay, it looks like we only have 2 minutes for August minutes. We're not going to be able to get to all of the SPSC business if DMH is joining at 12:15. So, how about we just move along to the August minutes?
That sounds fine to me, Marla. It looks like, unless I don't have an up-to-date draft, that the draft of the minutes isn't complete, so we might want to defer that also.
Okay, great, Malika. So that's now deferred until October 2020. I do have a quick membership update. I see Beatrice Birch has attended in the last 3 months. Lynn has been joining. Also reached out again to Joanna Cole, former state representative of Chittenden County. Haven't heard back from Joanne. Had a nice chat with Lynn. Also, Zach is joining, and there are other 2 potential members, but I can give more of an update about that in an email if you wish.
This is Vicki. Marla, I'm sorry to interrupt. I just wanted to add that I apologize for I overlooked the August minutes, but I did send them to everyone this morning. So if you do not have a complete copy of the August minutes, please do let me know. It should have been sent by email this morning.
That's all right. How about, Vicki, just so everybody has a chance to read them, how about, since we have 1 minute now before DMH joins, how about we push the August minutes into October, and we'll do August and September and October. Is that all right with you and the members?
That's okay with me.
Yes, that sounds good.
All right. Okay,
Yep,
so
yep.
it is now 12:15, time to welcome DMH leadership.
Good afternoon. This is Sarah Squirrel. I hope everyone is doing well. Thank you for the welcome. I don't know if there's any other preamble or if I should just jump in. So I will follow the committee's lead.
Hi, Commissioner Squirrel. Just jump right in, please. Feel free.
Okay, great. Thank you. It's so hard not being able to see everyone in person. But again, thank you for having me join today. As Eva noted, we have folks from, let's see, Karen Barber from DMH, as well as Deputy Commissioner Morning Fox. Are you on as well?
I am.
Okay.
Just trying to get my video working.
Okay. Yeah, I didn't see a lot of folks on video, so I turned mine off. But is this committee typically have folks on video, or is it just kind of a mix? I see
It's a mix of video and phone, Commissioner, and welcome Karen and Fox as well.
Okay. And Karen, can you just say hello to the group, please? And if you have your video, that would be great as well.
Sure. Yep. My name is Karen Barber. I've met some of you. I am General Counsel for the Department of Mental Health.
Great. Okay. Well, I will continue to proceed, and because I can't see people, if there are questions as we go along, I'll just defer to the committee to help manage that. But I do want to thank the committee, of course, for your continued work. Someone shuffling their papers, but that's fine. If you want to mute yourself, that might be helpful. But certainly, I really value the input of the Adult State Program Standing Committee. And as I mentioned in my email to folks related to their response to your questions, I think the Adult State Standing Committee and the partnership with the Department of Mental Health is really critical, that this is a table where we should have great dialogue, where a diversity of perspectives should be heard and valued. And I think that work is so incredibly important as it relates to your very important role related to the designated community mental health agencies, and also more broadly to the system of care as well. The Adult State Standing Committee has been around for a long time. It was created in 2003, which I believe at that time was when the Department of Mental Health and the Department for Aging and Independent Living were actually one department. And certainly the role and scope is really important. As I mentioned, in terms of just the big piece that you all do related to the designation of our community mental health agencies and that redesignation process, input on key hiring positions for the department, evaluating the quality and responsiveness of our designated community mental health agencies, providing input to the department related to other policies in the state system of care plan, and of course looking at that aggregate data related to grievances and appeals, and to really articulate where there might be opportunities or recommendations or changes to the system. So DMH did send, there was a letter that came from the standing committee, really, I think, wanting to kind of clarify role and responsibility. And I think some of it is process too, in terms of how we move forward. I'm happy to kind of walk through at a high level some of our responses to some of your questions. But certainly if there are specific areas, I think there might have been up to 12 or 13 items that you had outlined. I'll do my best to try to address each of them, but in the interest of time, if you're feeling like there are specific areas that you want to spend more time on, please let me know. Certainly want to hear your input as we continue to work on that collaboration. So maybe I'll just pause there and see if I, kind of walk through at a high level some of the department's responses to those questions. Does that seem most useful and helpful to the committee? Can't see nodding heads, so someone might have to say something.
Works.
Okay, thank you.
And I have muted folks on the phone, so *6 if you'd like to unmute yourself to talk.
Great, thank you. Just want to make sure that I'm on the right track.
I'm sorry, this is Vicki Warfield. I have a comment, if that's all right.
Please.
Thank you. I think the intention of this letter was to just get a kind of a written record to organize so that we have a record of exactly what our duties and responsibilities are. Is it possible for us to get a written response from DMH on the points outlined in the letter?
Oh, My apologies, Vicki. I thought that we had sent that last Thursday to members of the committee.
Yes, I will resend it to you, Vicki, so it should come to the top of your inbox.
Oh, okay. I apologize for that. Thank you.
No problem. We wanted to make sure we got it to you in advance so you had some time to review it and reflect on it before today. So again, I'll do my best to walk through it at a high level, and then there may be some areas that we'll have to come back to in subsequent meetings as well. The other thing I just wanted to note, some of the questions, related to specific topic areas as well. Part of the information that we sent was kind of a schedule of when key leadership from the Department of Mental Health might be coming to meet with the committee. We thought that might be helpful just in terms of kind of seeing the slate of DMH leadership, what specific content and topic areas you as a committee may want to dive into. Again, that was intended to be a starting point, something for you as a committee to reflect on, to see if that might be useful and helpful. But we thought kind of outlining kind of a year's schedule in advance with some of the key content areas might be helpful from an organizational standpoint. So some of the first questions were related to kind of feedback format. Certainly there's, I think, when it comes to the designation process and redesignation process, the designation reports themselves become a little bit of the process in terms of feedback. We certainly, I think, as has been articulated, want to make sure that we're really clear too. There's obviously dialogue that happens at this table in terms of you responding kind of during the meetings to questions that we may have or things that we're putting forward. We want to make sure that we're clarifying when there might be more formal feedback that is required, when the committee would like to, submit something in writing. I would assume that you may be making comments in a meeting or questions that you might want to think about more as a committee before you would consider it formal feedback. For example, if we were talking about the new physically secure residential, you may as a committee have some initial comments that you want to make more formal and recommendations. So I think DMH is really committed to wanting to think with you about what those formal templates look like that we can use to help support the committee to ensure that you're getting that opportunity. And it might be as simple as, if we are built-in formality to it, but as we're bringing other policies, systemic issues to the committee, we may want to stop and pause and say, and actually ask the question, how does the committee want to proceed with providing feedback? Do you want to do follow-up with something in a written format? And our team at DMH really wants to work with the committee on that as well. So that's an opportunity area. I think that DMH, Eva and Jess can help try to support as we go forward. There were some questions and concerns related to role clarification as well. We did highlight, I think this was specific to the think tank. I think we had some folks who participated in the think tank who were on the Adult State Standing Committee, and that perhaps the department, we made some assumptions about their role in terms of representing the Adult State Standing Committee. So we just wanted to apologize for that misunderstanding, and certainly want to make sure that as we go forward, when DMH has these kind of, big public facing, whether it was the listening tour or the think tank, that we're really clear about when you as a committee member participate, are you representing the committee as a whole, or are you just participating as a member of the community? So we just wanted to note that we'll be much more careful about being clear in terms of those roles going forward. And I'll just kind of keep moving and hopefully can get through a lot of them, but please, if folks want to pause and dig into something a little more deeply, let me know. In terms of the hiring of key management, I do think this is an area that the department can improve upon and do better. We did outline in the communication back to the committee what we would think of as key management positions as outlined in kind of the charge and role of this committee, that you will advise the commissioner in terms of key management hiring. This is also aligned with how Dale utilizes their adult state standing committee as well. We've identified some of those key management positions as the mental health services director, the quality management director, the children's services director, the adult services director, and our policy director. So we do have one of those positions currently open due to the hiring freeze. Our policy director position isn't something that we can fill right now. So I do believe that like for the quality management director, this was something that should have been brought to the committee to review. So I apologize that did not happen. That was an oversight on behalf of the department. But as we move forward with the hiring of the policy director, that will be a great opportunity for us. I was speaking with the Commissioner of Dale to get a sense of how they work with their adult state standing committee in terms of bringing final candidates to attend the adult state standing committee meeting. Certainly also as we go through the interview process for you to give us key questions and things that we want to be asking candidates. But certainly wanting there to be a more defined process for bringing those final candidates through the committee so that you can provide advisement to the department. The other area that was identified was just being able to provide.
Can I speak up for just a second? I wanted to talk about the get a little more clarification on the hiring process, contributing to that.
Sure, go ahead.
Thank you. So unfortunately, I did not receive your letter before today's meeting, and it sounds like maybe other members may not have also. So I'm looking through it now, and it says that in the future you're hoping to bring the final candidate to attend an SPSC monthly meeting. And I'm wondering if we only speak to the person you've already chosen to hire, what role are we playing in you coming to that decision in the hiring process?
Yeah, I did. That's Vicki. That was Vicki. That's a great question. That's why I did speak with Commissioner Hutt this morning from Dale to try to get a sense of how they utilize their adult state standing committee for this. She had a recent example of a key management role, and they actually would have brought the final two candidates to their committee, but one of them actually backed out at the last minute, so they only ended up bringing the final candidate. But I agree with you as I was rereading this, thinking that, we would want to bring, kind of our two finalists to the committee, if you will. I also think there's an opportunity as DMH is proceeding with the interview process that you as a committee can submit questions that you would want us to utilize as part of that interview process, and then giving you an opportunity to meet with maybe those final candidates, and also to provide advisement to the commissioner on those candidates was how we were thinking about it. And again, that's aligned with how Dale is utilizing their adult state standing committee as well.
Okay, this is Ward. I had the pleasure actually of participating in the Department of Public Safety's hiring process for the Director of Training. And it was a really nice process, and they did include me in the development of questions, as well as opened us up to participating in 4 of the interviews. So it was very helpful, and I think if that could be done, I think at least a member from the committee might be nice.
Thank you. We can certainly take into consideration other ways that other departments are thinking about this. So that's a great suggestion and something we can certainly think about going forward and how we incorporate that.
this is Vicki. I just have one final quick question. I noticed that, like, I would think to consider the commissioner and deputy commissioner as key management positions within the department, and I've noticed that you don't include those, don't categorize those as key management. I was just wondering if you can kind of let me know the thought process behind that.
Yeah, those are appointed positions. Oh, go ahead, Karen. Karen was jumping
I
on.
was going to say. Those are executive level. You know, the governor appoints the commissioner and deputy commissioner, and so that's a process that they're political appointees.
Oh, that makes a lot more sense. Is that also true for the medical director?
The medical director is not a political appointee, but it's a contracted position. It's not a state employee. So the contractors go through the agency of administration RFP process, and so that's how those are chosen.
Oh, so you don't choose an individual, you just kind of contract with an organization that chooses and provides the individual for that position?
No, not necessarily. So individuals or, like a hospital may apply, but the RFP process is there's a whole administrative bulletin that sets out how the state can contract with folks and what they need to be looking in when we're making decisions on contracted positions versus actual state employees. And I'm sure we can send you that if that's something you're interested in. I can get Eva the link. So you can review kind of the state's contracting guidelines.
Oh, I'm familiar with the state's RFP process. It just seemed like I wasn't sure why going through the RFP process would preclude members' feedback from being valuable to that process or advising in that hiring.
Yeah, certainly, Vicki. I think that as we go forward, if there are contracted positions where it makes sense and we would put them at the same level as some of these other positions, that we could think about, elements of the RFP or those job duties and descriptions that are included. I think that would be fine if that's something the committee is interested in. But as Karen noted, it is a separate process that we have to go through under the agency of administration.
Okay, thank you.
Yeah. So one of the other questions, and I do apologize if folks did not get the email. Again, we had intended to send it out to everyone last Thursday. So hopefully, Eva, we've gotten that out to everyone who's on the Adult State Standing Committee.
Yep, it did go out last Thursday. I double checked on that to everyone's preferred email. And if anyone doesn't have it in front of them right now, it did go out to potential members as well so that you have a chance to review. If anyone didn't receive that, please let me know and I can forward it to you right now.
Malika, I searched through my emails and I don't have anything. Perhaps it got caught in spam or something. So I'd love you to forward that. But also, Vicki did just forward it to me, and I can't open the attachment, so I don't know if it's like a zip file or something, but that I don't know if that will be true for others, so that's my situation right now.
Hi, Eva. It's Marla. Also, I did not receive the letter from the commissioner on Thursday, and don't think I can open a zip file either.
This is Ward. I've received everything and can open it fine. Just for me, fortunately. Yeah.
And Eva, they're just Word documents, correct? From what I recall?
Correct. They're just Word documents. They should open like other things that we send. I've resent it to Vicki, Malika, and Marla. So please do check your email, but they're also coming physical copy to folks. But they, went out last Thursday. So if they're coming physical copy, it may not arrive until tomorrow or the next day.
Thanks so much. This is Marla. I just would like to thank the members and prospective members in DMH for processing this so thoroughly and responding to the letter, also verbally today in such depth. I think that's really great progress, and I'm very grateful, so thank you.
Thank you, Marla.
Excuse me? Hello?
Yes, go ahead. I was going to continue, but if there's another comment or question.
Oh, this is Lori Mulhern. I'm on the Children's State Program Standing Committee. I just wanted to let you know I was here.
Oh, thank
listening
you.
In.
Great. Nice to hear your voice. Thank you.
Okay. Welcome.
Okay. One of the other areas that was raised was just seeking feedback from the committees, feedback specifically to the division directors, our mental health services director, the children's director, adult services director. There is a good system in place we were referencing for the Act 264 and Children's State Program Standing Committee that seems to work well. This is aligned with the annual calendar that we sent out. So we as a department have some accountability for ourselves to make sure that we have the right cadence of division directors attending the Adult State Standing Committee meetings, that you can kind of look in advance at what are the topic areas that you want to address with the respective division directors. So I do think having a little more organization to that as we go forward will help. So that was what we were putting out there as a potential solution. And if folks, I apologize with any difficulties with getting the attachments of the email. If you want to take a look at that annual calendar, it was just intended to be a starting point for the committee. And then we can fine tune that as we go forward. But you can see where we have placeholders for specific division directors so that we can ensure that you're able to provide them with that feedback that is so important.
This is Micah. I was wondering if there is an organizational chart for DMH that we might be able to access. I remember looking for it online a while ago. I haven't looked recently. But is that something that is either publicly available or that the department could make available to us so that we can better understand the different roles and, you know, the organizational structure within the department?
Yeah, I don't know that our org charts are like publicly front-facing on the website. I don't see why we couldn't share with you an updated org chart just so you could have a sense of how kind of the positions fit and sit within the department. That seems reasonable. It might just take us a little bit of time to have an updated one to you. But that seems like a reasonable request, Malika.
Commissioner and Malika and the members in DMH, quite a number of years ago, great number of years ago, that sort of chain of command chart was shared with the SPSC when we were meeting in Montpelier.
Thank you. Great. So we can work on that as a follow-up, which I'm sure will be helpful for the committee in terms of looking at the org chart and leadership as well. Okay, so there were specific questions related to the services review and the DMH funded and DMH managed services. That is primarily the services through our designated community mental health agencies. So certainly I believe as part of the agency review and redesignation process, this committee reviews those services for each respective agency. They should give kind of a detailed picture of the quality and details of services and responsiveness. That's kind of the intent and purpose of that redesignation process. Also, I think what the committee is probably also interested as well is other key initiatives and new developments in the system of care. For example, the new physically secure residential redesign, the adult needs and strengths assessment, the ANSA that I believe our Director of Quality and Accountability did bring some initial information to this committee to review. And I think that we really look forward to bringing other systems level issues and opportunities to the Adult State Standing Committee to provide input on. One thing that is also a little further down in our response to the letter, I forget which committee it is, but I believe it might be the Children's Adult State Standing Committee, or no, it's the Mental Health Block Grant Oversight Committee, actually outlines kind of the slate of priorities that they really want to focus on, and that has helped us really determine what kind of systems level pieces we want to bring to the committee, obviously outside of the designation process itself and the community mental health agencies. So for example, the Mental Health Block Grant Planning Council has determined that housing, suicide prevention, and children's respite are kind of their top priorities. And so we're able to work to ensure that we're bringing them the right systems level pieces for them to review and reflect on. So probably having a sense of what the priorities are from this committee will also help us ensure that we are bringing you the right systems level information that you as a committee want to grapple with and provide input and feedback on.
Sarah?
Yes.
On that issue, I've been in communication with the House Healthcare Committee. Actually, they asked me as a member of the Adult Standing Committee if we were reviewing budgets relating in particular to new initiatives. And they mentioned the new mobile outreach initiative for Rutland, as well as the suicide prevention. So I'm curious whether you'd be have any issue with providing us with budgetary information relating to these new initiatives, so that we can look at the amounts of monies that are being spent and provide advice as to if we feel that we might think certain initiatives should be getting more funding than others.
Yes, I would wholeheartedly agree with you on that point, Dan. And certainly we want the Adult State Standing Committee to, obviously any of our testimony in the legislature is public, but what I'm hearing is probably more of a want to look at things more proactively when it comes to policy developments. We have, as part of our budget development, mobile response is an initiative that we have put forward. It is not currently in our FY21 recommended budget. And then the suicide prevention dollars are specific to coronavirus relief funds. And we put together kind of a slate of opportunities that we think will advance the system forward. So I do think those are policy areas that we want to ensure that the committee is apprised of and can bring to you to reflect on. And again, I think, having a sense of where your priorities are as a committee will be helpful as well as we move forward.
Thank you.
Yes, of course. The next questions are a little bit more specific to the designation process, in particular with the designated agencies and the specialized service agencies. So that is a big part of your role, a big part of kind of our accountability in the system of care. And certainly we also see an enormous responsibility as a department to do most of that heavy lifting. It's, for our teams to, go out and do the site visits, do the interviews. And then I think there were some notes, I believe they were from Ward in particular about, the committee's role is to be quality control on DMH. So we might go out and perform the actual review, and then we're bringing all of that information back to you as a committee to ensure that you can weigh in as you need to, as outlined in the designation and redesignation rules and roles. So that's something that we certainly want to, continue to pay attention to. I know there were some questions about the DA staff that come to attend the actual meetings of the Adult State Program Standing Committee. I think today there'll be some folks from CSAC who will be joining the meeting today. So we don't necessarily select which DA staff attend those meetings. We do invite the designated agency or specialized service agency staff to certainly make that determination. We assume that they're bringing the right people to be able to answer your questions, and certainly hear and understand your desire to hear from direct service staff. Certainly, as I sit with the team as we review redesignation meetings, the level of interview and outreach with direct service staff in terms of the site visits is very comprehensive. And I would agree fully that the voice and perspective of direct care staff is essential. And that's why all of that information is included in the site report, the site review report for you to review. So we basically do the heavy lifting to get all of that information, do all that interviews that includes direct service staff, and then bring that back to you to review. And certainly also as there are areas where concerns may pop up. I know that everyone on this group is certainly aware of the additional, I don't know if we're calling it a formal agency review. I believe we are, like with Northeast Kingdom Human Services, for example. We made sure that this committee was apprised, and of course we'll be providing you with any additional follow-up reports that happen as a result of that. The next,
before, just to clarify, you all are denying or declining our request to be participatory in gathering that information, correct?
So I think that the better way to look at it is we're just trying to make sure that we're consistent with Dale and we're consistent with the rules, what the rules kind of require of DMH and what they require of the standing committee.
This is Vicki. I have a quick question. It's my understanding that from the inception of this committee until just a few years ago, there was kind of a precedent and an established policy of members of the committee accompanying DMH on site visits. And I'm wondering what was the cause behind the policy change that now prevents us from doing so?
That's not something I was personally aware of. I don't know.
If I can try to jump in, Karen, I think you and I started probably within a year of each other. I started in 2016. That was the tail end of the previous cycle. And at that point, we didn't have committee members joining the site visits. So unfortunately, it sounds like it was probably the 2008 through 2012 cycle, which I don't know if anyone who's currently on the phone is able to speak to it. I think it was something that didn't happen this cycle. It didn't happen the previous cycle. So I do want to acknowledge that if someone has a history of attending the site visits as a state program standing committee member, and you are aware of something, please share with us. I haven't found anything in writing in terms of policy change.
Can you hear me?
Yes.
Yes, I did attend a site visit to Washington County Mental Health at one point in the 2000s. I think it was, not sure the year, but anyway, Thelma had also joined. I think there were a couple of others. I think we're already at 12:50 p.m. So this would be something to share more about in an email discussion. I want DMH and the members to be aware that CSAC is joining us at 1 o'clock, and we had a scheduled break. We also still need to assign questions to members for CSAC, I believe.
Thanks, Marla. This is Malika. Yeah, I think a lot of this we need to, many of us weren't able to look at the letter till today. So, and there's so much discussion to be had. So it probably makes sense for us to review and sort of respond either at our next meeting or in writing together. But I did go on a site visit as part of the standing committee, and that was in my previous term on this committee, and I started working at HCRS in 2013, so it was not earlier than 2014 that I went on that site visit. So I'm not sure what the history is there, but it definitely was 2014 or later that we were last doing that.
Yeah, and one other potential suggestion for the committee to contemplate is maybe communicating any questions or expectations to the local program standing committee. All of the designated agencies are required to have those. We certainly want those folks who know their agencies really well to feel empowered in that role. So I would just invite this committee to think about how you might want to consider communicating specific questions to the local program standing committees of the designated agencies. As one way, if you're feeling a sense of additional concern or that level of involvement, that might be a nice way to forge that kind of connection and direct communication with the local program standing committee as well, and they might appreciate the opportunity to do so. So that's just a suggestion for folks to consider. The next big piece was related to the state system of care plan and the involvement of the state system of care plan. The state system of care plan for the adult system is updated every 3 to 4 years. This was something that our previous policy director was starting to work on before they departed from their position. With the hiring freeze, we are not able to hire for a policy director right now. So as soon as we are able to fill that position, we will certainly begin that work in earnest. And we'll want the Adult State Standing Committee to be very involved in the system of care plan. And certainly we apologize that that important work has been put on hold, but want to assure you that you haven't been left out of the process. We've just had to hit the pause button a little bit. I am hopeful that sometime soon we'll be able to move forward with our policy team being fully staffed, and the new policy director will be able to take a key leadership role in moving that forward. Okay, I'm also keeping my eye on the time, knowing that you've got folks from CSAC that are coming at 1. There were several clarifying questions related to some areas that the State Standing Committee will kind of have a working knowledge of, kind of priority areas of focus. And again, consistent with your roles as advisors to DMH, we want to assure that you do have working knowledge of some of those items that were mentioned: regulatory requirements, community and department pressures, outcomes, new initiatives, etc., which is some of the pieces that we've been talking about. And again, I would encourage the committee to consider specific priority areas that you would like to focus on, so that we can be sure to bring those that feel urgent and important to you to your attention on a consistent basis. I believe both Dan and Marla are on the Mental Health Block Grant Planning Council, so they might have some specific feedback on what has worked or hasn't worked that also might inform this committee, so we can ensure that we're bringing you the information that you need. The next area I feel like I would kind of highlight it as policy recommendations, and the committee really wanting to understand their role and to clarify your role as it relates to broader policy recommendations. I do think there's an opportunity, once we have our new policy director hired, that we can kind of sit down together and really kind of hash out how that communication should happen. Certainly policy development here at the department, you know, there's a process here by which we're thinking about system of care needs, thinking about the policy that will be required to advance those needs. I think the 10-year plan that we've articulated also will become a framework for how we will prioritize policy decisions moving forward. So I do think, there's a lot of opportunity there for us to continue to work collaboratively between DMH and the Adult State Program Standing Committee. And I know some recent examples of some of the policies that we brought to the committee's attention include the bundled case rate and the value.
Hi, it's Marla. Thank you so much. We really need to move along to assigning questions for CSAC.
Okay, well, I will, out of respect for the committee's time, I will wrap up there. There were certainly a few other questions, Marla, related to grievances and appeals. I'm hoping our responses are clear for the committee to reflect on. And again, just want to thank the committee for your time today. I really do think that it is so important that DMH and the Adult State Program Standing Committee work in collaboration to help advance the system to improve wellness for Vermonters. So just wanted to thank you all. And I think we've got that draft schedule for you to take a peek at as well in terms of kind of the schedule for key DMH leadership to continue to participate.
Thank you all as well, and thank you, Fox, and thank you, Commissioner Squirrel. Malika, do you have the questions in front of you? Do you want to break those down quickly for us?
In front of me, if you need them.
I have right in front of me. We can run down the questions really quickly, like just alternate them by member.
Yeah, or we could just take a page at a time. I don't know how many pages there are exactly.
Sure. I have them right in front of me. Should I start? Number one, designation.
Wait, hold on, Marla. I just would like to suggest maybe we don't need to go through each question. We can just, there's 5 pages of questions. How many people do we have here on the committee?
We have Ward, myself, Malika, Dan, Kate.
Salma.
Salma?
Yep, I'm here.
Okay, Salma.
And Vicky.
And Vicky, sorry. Yeah, I feel rushed now since we have like 2 minutes to assign questions.
Yeah, that's fine. And so I'm just noticing we have 7 committee members and 28 questions, and that's divisible by 7 quite conveniently. So if we just decide who wants to go first, second, third, fourth, fifth, sixth, seventh, we can just go 4 questions at a time, and then we don't have to go through the whole document.
Right. Why don't you take charge of that, Malika?
Kate, you were going to say something?
Yeah, I was just curious which document you're looking at for the questions. I'm sorting through a number of them. Can you point me towards which email they got circulated to, or?
It's a document. Oh, sorry.
It's the questions from the State Program Standing Committee for CSAC. All of the questions, it's 5 pages.
Okay. I've got it as 3.5 pages, and there's 28 questions there.
Kate, the name of the document itself is called Designation Questions from AMH SPSC 8/10/2020.
Thanks. Yeah.
Does anyone want to go first in asking questions?
I'll start, Malika. It's Dan.
Is that Dan? All right, so let's go Dan. I'm just going to do this totally randomly. Selma, great. Who wants to go next after that?
So it's Vicky.
Vicky, great.
I'm still
9 through 12, right?
What's that?
So I'm 9 through 12, correct?
We're alternating.
Yeah. That's right.
Alternating.
Number 1 is Dan. Number 2 is Salma. Number 3 is Vicky. Number 3 is Marla. Number 5.
That's not what I'm suggesting. I'm suggesting we go 4 questions at a time. So Dan would have 1 through 4. Selma would have 4, 5, 6, 7, 8, 9, right? 5 through 9. Vicky would have, or is that 8? 5, 6, 7, 8. No, 8. 5 through 8. And Vicky would have 9 through 12. Let's do Kate, 13 through 13, 14, 15, 16. I'll go next, 17 through 20, Ward, 21 through 24. And then who am I missing? Oh, Marla, of course. 25 through 28. Does that work for people? I can run through it again, but taking chunks like that?
Yep.
Works for me.
That's fine,
Sure,
but
very
I'm still having trouble finding this. I'm wondering, Eva, is that something you could send to me quickly?
Yeah, I just re-forwarded it to you, so try checking your inbox.
Yes.
If it doesn't come through, let me know.
So Dan is 1 through 4. Thelma is 5 through 8.
5 through 8. Yep.
Nikki is 9 through 12, and who's 13 through?
Kate is 13 through 16. Malika 17 through 20. Ward 21 through 24, and Marla 25 through 28. And I would suggest, if that works for people, we can have a little bit of flexibility about it. So if I get to question 20 and I'm like, oh, Ward, this actually goes with 21, why don't you take it? Or, you know what I mean? We can be flexible like that.
I'm sorry I was late. I couldn't get on Skype, so I had to call in.
I think that's most of us, Selma. We're mostly on the phone.
Okay.
And I have a question. This is Kate, looking at questions 15, 16, maybe 17. I'm wondering, do we want to edit those at all?
I'm not sure what does the red mean?
Red is edits that, this is Eva from DMH, I added in because this was part of your generic question list. And so the blank was, you had traditionally put one program in there or two programs in there. And so I added the red to try to clarify, is there a particular program you're interested in?
Okay, I don't have the reds, but Malika, that was extremely efficient. Thank you.
Yeah, no problem. But Kate still has this outstanding question for 15 and 16. Do we want to identify a particular program that we're asking those questions about? I don't really personally have an opinion. Others speak up if you do. But otherwise, Kate, I think if based on what you're hearing or your own opinion, you want to ask about, CRT or therapy or whatever, or intakes, those are some options that come to mind.
Okay, I don't know if any of those are pressing, or if, given the time, if we should drop these questions. If others are feeling more important, I'm happy to do either. I'm not sure which one I would select based on.
Just to give a heads up, I will, when CSAC joins us, they may have already. It's past 1 o'clock. I will say, that these are 28 questions, and we don't need long ad nauseum answers. We need to get through a lot, so we just kind of use your intuitions as we go along.
Okay, got it.
And I think it's fine if we come across questions we want to skip. I personally would love for every committee member to feel empowered to make that call. We probably won't have time to talk about all of these anyway.
Mm-hmm.
Hi, folks. Sorry to interrupt. I just want to let you know there are CSAC folks on the call, and this is Rachel Cummings. I'm the Executive Director.
Hi, Executive Director Cummings. Welcome. Who else is with you?
Dr. Jimerson is here also.
Hi, Dr. Jimerson.
Good morning.
Anybody else from CSAC?
Sandy Smith.
Hi, Sandy. Welcome. All right. Why doesn't DMH and the SPSC do a quick round of introductions? I'm Marla Simpson, member of the committee chairing the meeting today.
I'm Thelma Stout, member of the committee, and I work at CSAC.
Malika Puffer, she, her pronouns, manager of peer support services at HCRS and member of the committee.
Dan Toll, peer support operator for Pathways, member of the committee.
This is Ward Nile. Oh, sorry. Go ahead, Kate.
Sorry. Vicki Warfield, she, her pronouns, member of the committee.
Ward Nile, member of the committee.
Kate Hunt, member of the committee.
And on from DMH, we have Eva Dayan, Trish Singer was here, maybe back, and Jessica
Still
Bernard.
here.
Oh, there you are. Going on video now, just to be fun. And just so that everyone knows, this meeting is being recorded, and as a reflection of the minutes, it is posted on the DMH website under the State Program Standing Committee.
Okay, thank you, everybody, and hi, Trish and everybody. Welcome, CSAC. We have 28 questions. We advise and gently suggest not to go on very, very lengthily with each question. We have a lot to get through. We'll use our intuition and have an open-ended dialogue pertaining to these 28 questions about CSAC. So we're excited to meet with you. Dan will start us off.
Okay. Can you folks hear me?
Yes.
Okay. All right. To start with, the first issue is I'm referring to the agency designation report. And in that report, there were two major areas, program level areas that did not meet standards, and they were the governance and comprehensive service. So if you could just talk to us first about the governance issue related to bylaws, and specifically how challenging will this be to address, and what steps you have or will be taking to correct this area. So I guess the first would be the governance issue, specifically bylaws, and the second is under the comprehensive service system, meeting the needs of high needs clients, as well as addressing staff trauma to be more recovery oriented. And then related to that is steps being taken regarding violence, apparent reports of violence related in the Rock Hill House.
Let me quickly address the bylaws. We have just updated our bylaws.
Your audio is very choppy. I don't know if it's just me.
Sorry about that. I hope this is better. Our internet connection might be a little down. Specifically to the bylaws, we had just updated our board bylaws after the designation report came out, but we did submit a plan to the state to include the disposal of assets to be incorporated in the bylaws by January 2021. So we have a plan for that, and we are on track for that. Does that address the bylaws in a succinct manner?
Excuse me?
Does that address your question on the bylaws?
Yes. Yeah.
Okay.
Thank you. Yes, thank you.
Rachel, Bob, just checking in. It is difficult to understand the communication, the way it's coming across the line right now. So just I don't know what can be done to improve it, but it's challenging.
I'm going to call in with a phone call.
Would you like to phone in, because the internet is very muffled and it's difficult to understand?
Yes, I will phone in.
Okay, thank you.
Thank you.
Great.
And this is Sandy Smith. I'm the Director of Adult Mental Health Services here at CSAC, and I can speak to the next section if we're ready to go to that. I guess I have a question though before doing that. Is this primarily a audio only call, or are some people getting in through a video connection?
Both.
Both? Okay. I couldn't find the video link, so I'm phoned in obviously at this point, but maybe we'll try to link in more directly by video when I can.
I couldn't get the site to work, Sandy.
Okay.
Yeah.
Okay.
Yeah. Don't this is Dan. My opinion, don't anybody worry about being on video. Audio is fine.
Okay. Okay. Well, let's just go with that. And so the finding about under comprehensive service systems, I guess that's a complicated one to respond to, because on one level, yes, there's work we want to continue to do around trauma, being trauma-informed, vicarious trauma, and the impact on staff. All of that, and that's a major area of agency focus in this next stretch as part of our strategic plan. We'll probably speak to that later. But I also think that overall we do have a really good comprehensive service system already in place in terms of how we respond to people in distress and try to hold and carry that distress in community settings, and also in terms of really minimizing where we can the necessity of hospitalization, both voluntary and involuntary. I think this came out of some experiences where maybe DMH folks were wishing we'd take people more quickly into settings, and in some of those settings like Hill House and Robinson House, the impact of violence in those houses has resonated there, and so we've wanted to be careful, both for the benefit of residents and the staff working there. It's complicated to keep entry-level staff who are not paid a lot, keep them doing this work in a positive, engaged way if there's episodes of violence directed at them. It's also complicated to ask other residents to tolerate feeling unsafe in their own home. So, I think these are both things that we've really tried to work on very intentionally. And, with adding the MyPad project to our region now, I think overall, we have had already low rates of hospitalization. I think they're going to get, where we might have 2 to 4 people in at any given time, we're going to be more in the range of 0 to 2 people, with stretches, I think, of really not requiring hospitalization. So I feel really good about what we've developed here, and I think it's a bit of a thin narrative to say that because traumatic things have happened, that treating that trauma in itself is going to make it more tolerable for people to be subject to experiences where they might get hurt. And so I want to kind of make that distinction in my response to that question.
Bob Jimerson, just checking in. I would certainly agree with Sandy, your perspective. And actually, I certainly respect that some feedback came up that brought this concern about some limitations in serving high needs clients. But that's just an extraordinary commitment that CSAC has had and will have. At another point, if there were concerns about reviewing some of what's occurred in residential programs, I'd be very happy beyond this conversation to discuss that. What I would emphasize that's quite important for communities that are serving high needs clients and the individuals is capacity to access higher levels of care in a timely way, which is quite difficult currently in the system of care. But I appreciate the concerns. I think it's always a priority to serve high needs clients, and certainly an awareness of the impact of trauma and how better to work with issues of trauma is an ongoing important area of endeavor.
Okay, thank you. The next question relates to open dialogue. Could somebody just very quickly give a summary of where within CSAC you're using the open dialogue methodology, and maybe give an example of how that's working.
This is Sandy, and I'm sorry, I was talking with video here. I'll close that out for now. So Open Dialogue is a project that really goes across our departments, and I think that's been one of the unique features of our efforts with it. And whoops, am I echoing? I'm just trying to close the Skype on my computer now. So, you know, we pick up referrals from the emergency team. We use it a lot within CRT with our long-term populations. We use it consultatively with other populations. There's staff participating from psychiatry, emergency team, CRT, adult outpatient, adult stabilization team. So it's, you know, really meant to be something that is cross-departmental collaboration. You know, the bulk of the work probably has been with E-team referrals and within CRT.
Okay, and so overall, do you feel as though the agency is implementing the open dialogue collaborative, the CAN process effectively?
I think we've made a huge effort, and you know, we're one of the kind of you know, lead agencies piloting this in Vermont, you know, there's open dialogue as a kind of complete service model, and then there's open dialogue informed practices applications, and we're doing some of each of those. You know, so as a complete service model, you might have, you know, really at the start of services, the forming of the network team, and you know, really that becomes the framework where the rest of the services get worked out. And other applications might be that we use a kind of collaborative reflective process in a network meeting in a residential program, or as a consultation for a stuck situation where everyone's trying to figure out what's going to be helpful next, but it isn't the full open dialogue model. My own opinion is we could do a lot more, that we could use it more at the start of services and at times of crisis, and you know, really try to kind of stay with that framework more fully in more situations where the participants, you know, want that. If they're agreeing to it, then I think there's more we could do with it. The challenge is the staffing model doesn't in itself match up well with the kind of historical ways our systems have been organized and the funding that we have for organizing services. I also think it's really a kind of a template and a catalyst for us in terms of our kind of guiding values and how to work more purely from a recovery philosophy and really embody that more fully. And you know, I view it as something that's already been leading us through some paradigm changing shifts in our practices, and also I'm hoping that it can be more of a template for where we go forward from here around how we organize services.
Right. So it sounds as though it's embedded in your practices in many ways, but you also see that there are areas where this approach could be further utilized to improve your delivery of services. Yeah. Yeah. Great. Thank you very much. The next question, there's really two issues here. The question is sort of a broad one about what does informed consent look like, and how do you ensure that? But it's and then sort of related to that, or a subset of that, but a very important issue, which I'm interested in hearing more sort of your broad philosophy, and that is relating to the issue of your philosophy about medication and about and how that relates when it comes to transitioning people safely off of psychiatric drugs, or not prescribing them to begin with, if that's if that can be accomplished.
Sandy, would you want to start on that, and I could follow up and talk more specifically about approaches to medication?
Sure. Yeah. No, I think, the kind of values of, as we were talking about earlier with open dialogue, the collaborative, the values of collaboration and transparency are important to us. So really talking about, with any service we're offering, what is it that we're trying to do? Is this something you want to be participating in, given what we've described? I think is a really critical part of engagement and I think kind of ethical engagement in services. So, I think overall, informed consent guides much of what we do. I'd say it's, we're probably less formal about it, in terms of kind of having documents and things than maybe some centers might be, but I think the values are strong for us. And Dr. J, do you want to pick up regarding medications?
Yes, one is certainly in regard to informed consent around medications broadly. So every new prescription is associated with a conversation between prescriber and client, talking about risks and benefits, talking about approaches to follow up, careful review of our readiness to respond to any concerns about side effects. Overall, we really try to build a collaborative model in regard to our prescribing. I think importantly, that's also, recognizing that medications, unfortunately, are really quite imperfect, and that there are, important things that really do need to be closely monitored, including a number of potential medical risk issues that can occur with medications. Certainly notably with medications in the antipsychotic area, there's a broad concern about adverse effects on metabolism. So that's a very important conversation, and one that, I think in regard to prescribing needs ongoing follow-up. I think conversations really need to be developed very individually with clients, being sure that there is an understanding in regard to medication. We are really open to recognizing that individuals may choose or prefer not to proceed with medication. Myself as medical director, I'm a believer that often psychosocial treatment engagement, individual family work may provide an alternative to medication. There are times where combined treatment seems to carry more efficacy. We have been open to working with individuals with very high levels of disturbance, following them not on medication. I think the open dialogue work that Sandy originally was responding to a question about has been very engaged in some particular very, very intensive longer range follow-ups with individuals. I think likewise there is an important recognition that individuals who may have been on medication for some time, it may be preferable to proceed with tapers off of medication, both from the point of view that I have psychiatrically, but also respecting individual preferences. I do think that the best approach to medication is collaborative, ongoing connection with both individuals therapeutically, as at the psychosocial level, as well as with psychiatry. I think ideally there might also be opportunities for settings that offer even more robust support than we're capable of doing currently in the models that we have to support individuals going through difficult periods of transition who really have a strong preference to not be on medication. So I think that's an important area for continued exploration, both within our program, but also more broadly at the DMH level. So those are some thoughts. Let me see. Have I responded to the question adequately?
Dr. J, I have a question. It's actually from question 8, but I'll ask it because it fits what we're talking about right now. What is CSAC doing to avoid incorporating multiple medications with folks, and how does that process work?
Well, it's I think it's an ongoing review. I mean, my view is that it's optimal, to think about parsimony when it comes to medications. And I think overall, I think psychiatry is going through an era that I have concerns about in regard to multiple medications and being prescribed. I think there's some areas that are really especially concerning here when there are 2 medications in certain areas, antipsychotic medications particularly. Now, arguably, some individuals may appear to do better with 2 antipsychotics, but it's concerning. I mean, I think the era of shorter hospitalizations has often ended for individuals who have required hospitalizations to medications being patched on rather than medications being taken away. I do think there are areas where multiple medications may also be quite important in certain presentations. One of them is certainly in the complexities that may present with individuals with bipolar disorder, where there needs to be careful assessment of the role of mood stabilizing medications. Sometimes antidepressants have a role. Addressing sleep carefully is important. Trying to limit and be cautious about longer range use of benzodiazepine medications is important in all clients. So it's a challenge. I mean, I think it is something that we often consult with each other about on the psychiatry team, and do bring forward in conversations with individuals we're serving about possibilities of reducing medications. So that's where I am with it. I think it's. I think we are working again with medications that are really largely imperfect. I think I made some references to bipolar disorder. I think unfortunately we often see that certain medications that can be really helpful for some individuals, like lithium, are frequently not being initiated, and we're trying to think thoughtfully about that. And
Great.
And likewise. So let me stop there.
Yeah. Great. Thank you very much. Yeah, I just as a psychiatric survivor, long-term medication taker who's in the process of tapering, I'd encourage you to continue to look at the non-medical, psychosocial, holistic approaches and minimizing the medication piece. The last question.
Dan, this is Kate. Can I just jump in with one follow-up question on that? I heard the medical director's comments. Thank you very much. And it sounds like you are mindful of the same issues that the committee is. I'm curious about if a client, for instance, expresses a desire to transition off some of those antipsychotic drugs. I think what I heard you say was that that sometimes psychosocial involvement and that sort of thing can be therapeutic in a way that enables them to come off or taper off some of those psychiatric drugs. If a client says to you that they want to transition off, is there some way to close the loop? Are you closing the loop so that other professionals are perhaps beefing up or backfilling or increasing those psychosocial involvements for that client, so that as they're tapering down on the antipsychotics, they're perhaps, you can think of it as tapering up on that community involvement or those kinds of things. Are you closing the loop between those two arms?
Very much. We think that's a very important approach to follow.
Thank you.
So yes.
Mm-hmm. Thank you.
Great. Super. And my last question relates to the emergency department, Porter Emergency Department, the relationship between Porter Emergency Department and CSAC, and just interested in how you feel that relationship is going, how it can be improved, and also if you're using peers, how you're using them in relation to the emergency department. And I guess Porter, I don't think has an inpatient facility, but if you're using peers, how you're using them, and if you're not, why not?
Okay, maybe I can start out and others can chime in. This is Sandy. I reviewed this question with the coordinator of our emergency team, Marion Greenberg, who's out this week, and she wanted to make sure that she thought that maybe the report was not characterizing the relationships with Porter well, and really wanted to emphasize that the collaboration with the staff at the Porter ER is strong, that there's a lot of attention to relationship and teaming with them, and that's been going well overall. And recently they held a meeting with the director of the ER and talked about how things are going, including some of the COVID-related challenges of being off-site, which is a topic of continuing discussion. But I think the quality of that discussion was something that Marion wanted to emphasize is good, and that the quality of the kind of day-to-day teaming with the staff there is quite strong. I think there is another level, and maybe where the comments in the report came from has to do with the challenges when there's a stay in the ER while someone's awaiting hospitalization, and particularly under involuntary circumstances. And we've all been troubled by how difficult those situations can be. And I know our advisory team has been encouraging us to try to find other ways of getting at this, trying to find doable steps that we could work with Porter on to, make those experiences less challenging in any ways that we can. And it has been a little hard to engage a sustained conversation about that with the Porter team. So I think that maybe is where those concerns are coming from in the report. As I think Rachel can jump in at any moment when she has a chance to talk with Porter leadership, she's bringing this up. And whenever we're having any kind of forum or meeting with them, we're trying to look at this and just see what else can be done in that difficult space, in those difficult situations. In terms of use of peer supports there, we were starting to work on some plans to form a work group and see what we could do to get more support over there. at times when people are awaiting hospitalization, if it's something that they would welcome. And I think it was kind of a COVID thing that we didn't, we paused those discussions, in recent months, but I think it is something that we're trying to figure out how can we, peer or other outreach staff, just to be more of a supportive presence when we can. I think, right along we try to send anyone over that we can to be on site and be some support, but to have kind of more of a call list system or some group of people ready to really go help out is a topic we want to work on further.
Okay, great.
Hi, this is Marla. Before we move on to Thelma's questions, we do still have over 20 questions remaining in less than 1 hour.
Okay. Thank you.
Okay, the next question is, what is the status, and I can actually sort of not really answer this, but I'm going to let you guys answer this. What is the status of your transition to a new EMR, or electronic health record?
Hey, Bill, are you on the call still? Do you want to take this one?
I am on the call. Is my voice okay, or am I breaking up?
Very clear.
Okay. So the status of our electronic health record is still a work in progress. COVID-19 kind of stagnated the process progress we were making. We are still working out some of the bugs and trying to get the efficiencies up to where we would like them. We're working with the vendor to accomplish that, and we're working internally, although over the last few months it hasn't been a priority as much as it should be, given the COVID responses and management that we've had to put our focus on. But I can let Sandy Smith join in to this conversation. He might have some direct, clinical experiences he'd like to share, but that's a quick summary of our EHR. We're able to bill, we're able to report. We're still trying to figure out some things because it's still relatively new. Does that answer the question?
Yep. Okay, my next question is, how do you involve staff, supervisors, and the local program standing committee in deciding what trainings are needed throughout the agency?
So I can respond to this. This is Sandy. So under normal circumstances, non-COVID circumstances, this is an ongoing topic of discussion in any and all of our forums. But it's particularly in our 2 annual planning retreats that we try to step back and look at the feedback, look at the, whatever data we have to look at the, what are we seeing out there as promising practices that would better get at what we're trying to address in our work. And really, we're quite literally casting a global gaze, trying to find what could be most helpful, and with examples of trying to learn about models that can reduce coercion from the work happening in Trieste, Italy, or their work on social inclusion and meaningful roles, as well as Dr. Ferguson's work in Colombia, or today Thelma just had an excellent consultation with the Yale team around the Citizenship Project, and we had a training with them a few months back as well. So we're really hungry and eager to see what's out there that's going to help make a better difference in our work, and I feel like that's been a real strength of ours. And then we keep that like with the we keep those discussions going in our standing committee meetings, and some of these trainings have been done as a kind of combined effort, like the training we did with the Yale, the first training we did with the Yale team was really a mixed group of folks learning about the work they've been doing there. We had a presentation by Anna Florence, who had presented on some of her early open dialogue research in Vermont. That was an incredible discussion with people who had been in open dialogue sessions as clients or family members, staff, folks from the state, other stakeholders, and really where we can get those kinds of really rich multi-role dialogues, we just get so much from that.
Thank you. The next question is, how do you recruit for your local program standing committee? Do you make this group visible on your website or use any other methods?
This is Sandy. I think we could do more with the website, although for CRT, I'm struck by that's not a popular mode of finding information for a good, or an access problem really for a good chunk of folks that we work with in CRT. So we rely a lot on kind of word of mouth inquiries, just trying to say, hey, if you know someone who'd like to be involved in these kinds of discussions and planning, please have them get in touch with us. And if we hear someone really speaking up about something where they're thinking about our systems and ways we can do things better, then that's a good moment to ask them if they want to become more involved. And I think what has worked is our use of stipends, which is, I think, stabilized involvement. And I'm always looking for more voices, more perspectives to be brought into the process and really help us think about how we go forward from here.
Okay, and then the last question, this goes to Dr. J. Just a little more about psychiatry services, like what's being provided. I mean, one of the questions is there a vacancy? But I know that there's been a new hire. So just to address that real quick.
Surely. I'm really pleased, and I think, our team is broadly, that Joe Lessick, who had been at Howard for a number of years, joined us on a full-time basis on September 8th. And I am anticipating that Joe will transition to my position as medical director in January. My own intention is to continue at CSAC with some reduced hours to be assessed, but to be involved in a continued way. So this really, with our 3 full-time APRNs, this really addresses an existing vacancy, and I'm very, hopeful that actually Joe's joining us will give us some capacity to have additional accessibility in a variety of areas for psychiatry.
Thank you, Dr. J.
Sure.
Vicky's next.
Hey, Thelma, are those all your questions?
Yep, that's all my questions. Thank you.
Okay, moving right along to Vicki. Thanks, Vicki.
Okay, thank you. On the designation site visit report, are there any plans to address the concerns on page 8? The feedback shared by, I believe, a couple participants.
Could you specify which ones you're wanting us to respond to? I had a little trouble discerning what to pick up on there.
Absolutely. Let's see, I moved away from that page for a second. It sounds like clients would like more access to psychiatry services and more access to crisis services, which I thought was interesting because I believe crisis services were something you mentioned as feeling that CSAC was doing particularly well. But clients had mentioned that they hear crisis screeners ask if they are at risk of harming themselves or others, and then are frustrated when they do not meet this threshold, that support is no longer available on nights and weekends.
So I can start in responding to that, and maybe Dr. Jimerson, you can also jump in. I think we have a strong emergency team that actually is really pretty open to a supportive response in a wide range of circumstances. So not just saying, is this truly an emergency and these are the only circumstances under which we'll respond to you. But in fact doing a lot of supportive checking in, and if anything, I think we're probably at the far end of the spectrum compared with other crisis teams along those lines. So I'm not sure what to make of that feedback other than, nights and weekends, we do have really one person on as the lead, emergency team responder for the county. So then that does, become a limiting factor if they're getting in a few calls at once, in terms of how they can respond to those different situations. And they probably have to do some prioritizing in the moment and saying to some folks, look, I want to talk to you, but I'm going to have to call back in a little while. So that may be where that feedback is coming from. But I think overall I've really heard them in my discussions of how they're responding to things. They're welcoming of a pretty broad spectrum of outreach from folks.
Okay, thank you. That clarifies that pretty well.
Dr. Jimerson, I just wanted to tap into that additionally, just for a moment, and just say that I think one of the unique aspects of our emergency team is it really does work with a high level of integration with the other clinical programs. And, I think, when there's one staff person on call for the county, it may limit how much availability there is of that moment. But there's always an emphasis on follow-up with clinical teams, and I hope that's not experienced as off-putting, that there is encouragement to connect with clinical teams, with follow-up with the clinical teams between E-team, happening rapidly. But it's always important to hear these experiences that some individuals have had where they haven't felt that they've had an opportunity to get the support they needed, and we take that seriously.
I would also say that in CRT we have a weekend on-call support work system, so there are other people who can check in supportively to complement the efforts of the emergency team.
Thank you. I think I heard you mention, let me know if this is incorrect, that sometimes there's one person on shift to support the whole county for screeners. Is that correct? And are there any plans to increase that?
That is the case overnight and on weekends, there are ongoing conversations about how we might increase that capacity. Sandy, I'm sorry, I kind of...
Yeah, no, I think your response was good.
Great. Just two last things, kind of under that same question, number 9. It looks like DMH spoke with multiple clients that were unclear what the grievance and appeals procedure is. I was wondering if you could explain what the procedure is and how clients are notified. It looks like one client asked for a handbook and couldn't access one, and other clients may have had inaccurate impressions about the procedures.
Yep, no, that's a concern when we're hearing that feedback. The people can do grievances in writing or verbally request a grievance, so that we try to have things posted about this, and also readily, if someone's asking, to make the forms available that also describe the process. I have to say that we also, the most valuable thing is just to talk about what is the concern as quickly as we can, and put it in context and get the key players together to work it out. That's, to me, the best practice. And then hopefully, whether or not that travels through a formal grievance procedure, I think we're getting a timely, thoughtful, contextualized response from, when needed. So that's our kind of overarching value, is to aim for that. But yeah, people should know and have access to the information about how to formally file a grievance.
Hi, this is Rachel. I just wanted to add we had an open position for our quality and compliance officer where the formal grievance policy or process was held. That's now been filled, and there's certainly opportunities there to do some education and some outreach with clients to make sure that they understand what that process looks like.
But currently there are no plans to for any specific updates?
Well, we had been working on a internal program handbook, which we had almost finished a while back, and then made some program changes and paused the project. But I think, you know, tools like that just have useful information about how to, you know, a whole bunch of issues around the program, but including a reminder about grievance and appeals procedures, and as well as other mechanisms to address concerns and offer feedback. You know, I think more systematically putting out, you know, all the different ways that people can, you know, address something or have input on things, you know, is still something we need to work on further. And, you know, certainly with that role that Rachel's referring to having been filled, that'll be a good resource for that.
Thank you very much. I do want to be mindful that we have limited time, so I'm going to wrap up question 9 just with a concern that I've come across with grievances and appeals as having been a patient representative within inpatient facilities, which I know is a little bit different from you know, the demographic that you guys serve. But I'm wondering, you know, being mindful of the differential in the difference in the power dynamic between kind of client and case manager or client and designated agency. Is there anything in your grievance and appeals procedures that protects confidentiality within your organization and protects clients from retaliation that the clients would know about, so that they would feel comfortable if they had a problem with someone in the organization that had significant power over them?
So whoever is doing the lead response to, you know, address, you know, hear what in more detail what the concerns are, that's one of the very first things they'd be checking out is, you know, the different options for addressing this, for inquiring about this, and what level of privacy is needed, or, you know, what, just to review what the choices would be to follow up further out of respect for those concerns. And certainly, yes, no, any kind of retaliation would be a, you know, is something we would take very seriously, and just you know, grossly unethical use of power. So yeah, we should try to pay close, sensitive attention to those concerns.
I appreciate that. So as a client, if I wanted to file a grievance, I was concerned about something within my care team, how would I know who to file that grievance with other than my care team?
I think the forms will say who the grievance and appeals coordinator is, you know, what your options are for accessing that person, and you know, or other options for how to get the form in, so you don't have to go right through your team.
That's awesome. That's exactly what I was asking. I know some DAs don't have one designated person to receive grievances, and I think it is very helpful to have that. So moving on, what is the agency doing in terms of ease of access for clients to get back into services after termination?
Can you give me a little context to that question? Is that something you heard as a concern in a particular department, or is this just more of a general question?
Yeah, the member that came up with that question here right now to kind of provide the thought process behind it.
Which number is that, Vicki?
110. In regard to getting back into services after termination. And I apologize, I didn't write questions.
We still have a total of 28 questions and less than a half hour, 35 minutes.
Okay, so maybe I can speak
over that one.
Well, okay.
We can just skip over that one for now. I do know we're running short on time. Then number 11 is about the police. In which situations do you rely on the police, and are there any plans or efforts to reduce situations when reliance on the police occurs?
So I can start with that. So in our residential programs, it's really when there's you know, physical violence or kind of an imminent threat of physical violence or something dangerous happening where someone might be, in some kind of immediate danger themselves. Those would really be the situations where we might call the police to a residential program. And then for the emergency team, that has to do with, where we know that there's some very imminent danger in the community, where someone is, in kind of a very threatening situation themselves, or other people are, are in some kind of violent situation. But I don't know, Dr. Jimerson, if you want to speak more to that.
Surely. I think importantly, Marion Greenberg, if she were here, coordinator of the emergency team, would talk about, there have been multiple efforts to develop a more collaborative working rapport with both the Vermont State Police as well as the Middlebury Police, with their with heads of those services being invited to join with the emergency team, and there's an ongoing communication. I think that that's an area for continued development. I think we, in an ongoing way, are trying to think through a funding approach that might allow our team members more consistently to join police on outreach calls. I think that's a very important model, and there's some staffing limitations around being able to do that, particularly after hours and on weekends. So I think it's an incredibly important area. Some of us will again participate in an upcoming Team 2 training. I feel strongly that we need to think about approaches that might actually allow our teams to be first responders to circumstances where police have often been the first responders. So, the dialogue, I think, has been positive with our law enforcement community here, and there's more of that we need to move forward with.
This is Rachel. Just wanted to add that we are taking part in a interagency, cross-agency conversation with the Virgins Police Department on how we might figure out a way to embed non-police staff, clinician staff with the police force there. So just wanted to make sure you all knew that was happening. That's on September 25th. And we've also had outreach from both the State Police Barracks and the Bristol and Middlebury Police. I think, as Dr. Jimerson spoke to, our biggest barriers is funding. And I know the legislature has allocated some vacancy savings to see if we can sort of expand that program, and we'll see if CSAC is able to participate in that program.
That sounds really good. Is there any training being provided currently for staff to be able to respond to situations in which there's a concern for harm from a mental health perspective, rather than relying on law enforcement in situations where it's not necessarily a legal crisis or an issue of a law being broken?
Go ahead, Eddie.
Okay, well, I guess I'm not sure I understand the question. So training for, are you asking about training for staff to go out into a potentially harmful situation in the community?
Well, I think that the idea is if someone is a client, to use de-escalation and know how to respond to crises,
okay.
Or is kind of the policy just if there's violence, then it's the police issue?
No. I mean, I think that's always the go-to preference is to find connection, work on de-escalation in any way we can. I think that work that we've done with Open Dialogue has been helpful with that, and the trainings we've been able to get people into with intentional peer support. I also think the CPI training model focuses on de-escalation. Yeah, absolutely, that's way preferable, whenever possible.
I know that IPS does not train around situations in which police could be called, but it sounds like Open Dialogue does specifically address de-escalating crisis situations, or the other training you mentioned.
I'm referring to those two not because they specifically refer to that, because I don't think they do, and how they're put together, but I think what they do help staff to do is to calm down, slow it down, try to understand what's going on, listen very carefully, and also encouraging kind of more of a, to pay attention to power dynamics and to work from a collaborative stance and not a kind of threatening hierarchical stance. So that's why I was thinking of those practices as having good kind of de-escalatory properties.
Sandy, I'm also thinking about how when there is capacity, both emergency team staff and particularly some of the staff from CRT are doing outreach home visits when capacity is there. I think, historically, CSAC has been very loath to use warrants to bring individuals in for examination. There are rare instances, but I think, frankly, in contrast to some other DAs, we have really assiduously tried to avoid that sense of a first response by way of someone being brought in, often more forcefully, to the emergency room.
Yeah, thank you very much.
One of our, just about Open Dialogue, the power of working in pairs to hold a different kind of space that does allow for a kind of calming down of the situation and really trying to listen, I think is one of the things that's really stayed with us, that when things are tense, if you can work in pairs in a way, not to gang up in the situation, but really to team up around how to kind of hold a more open and collaborative response and really try to prevent the kind of spinning out and escalation that could otherwise occur.
Great, and it would also address, if escalation does kind of occur, how to keep clients safe and keep staff themselves safe in a crisis situation?
Absolutely.
I think that's right. I would also emphasize that our perspective on this is support for families and family resilience in the midst of sometimes just progressive, evolving crises is also an extraordinarily important part of the work. And I think the dialogic model has been quite helpful in some circumstances to allow that to proceed.
That's great, thank you. And my last question is, can you tell us about housing across the agency? What's new, successes, and any challenges?
Certainly, in terms of what's new, the big addition for us is this project informed by the MyPad projects up at Howard Center, where we have a building with apartments and then a staff space that's within the building. And this has enabled us to get people who really have had a hard time living in the community and have had really long stretches of hospitalization, to get them back out and successfully living in the community. And it's early going, and some rough spots as we were getting started, but really is showing a lot of promise for doing exactly what we hoped it would do. And it should take some pressure out of the system of care, and at the same time, it's really helping people to live in the least restrictive settings and get on a new stretch of their lives. So we're quite excited about this. We have 4 apartments. The fourth is about to be filled And I don't know how many inquiries I've had since we started. We could fill another 2 more. They're pretty staff intensive, but clearly there's a need for this balance of autonomous space and yet having the proximity of staff support and community. That you don't get that balance in a group home environment.
Just Bob Jimerson, a couple additional comments. Middlebury is a really tough community in terms of the lack of availability, often of affordable apartments. So this is a real challenge. What we've also seen and are deeply concerned about trying to work collaboratively at a broader state level in regard to is responding to the increased presentation of individuals with homelessness broadly in the community. Our Nicole Grubman, who heads up our stabilization program, has really been involved in, I think, in some terrific outreach to shelters. We have pursued a grant to try to develop more services. We're looking at collaborative community networking. So the issue is a broad one that I'm sure all of you are aware of in regard to the concerns of affordable housing that exist in the Vermont community.
Well, thank you so much for answering these questions. I really appreciate the thoughtfulness you've put into these answers.
Hi, this is Marla chairing the meeting. We still have questions 13 through 28. How do the SPSC members feel about prioritizing the most important questions? We have less than 25 minutes.
That sounds great, Marla.
All right, so Kate has the next questions. Please be succinct with your answers. It's a great conversation. Thank you.
Okay, along those lines, everyone, what I was thinking is I'm going to be asking questions 13 through 16. I'm considering maybe skipping the first one under the agency report about trauma treatment and being trauma informed, as perhaps that was touched on adequately when Dan was asking, but you can think about that as I'm asking my first question about to CSAC about addressing the needs of elders in your care. Are you who may have special needs? How are you addressing those the needs of elders?
Hi, Kate, this is Rachel. So we had a gap without an elder care clinician for about 3 years, but have successfully filled that position and staffed that position consistently for 3 years with a woman, Mo, who has been doing a fantastic job really not only providing services, but as importantly, collaborating with area partners like our Area Agency on Aging, Porter Nursing Home, Porter Case Management, Home Health and Hospice. We've also invested in Mo's education and training. We've been sending her to conferences, as well as she became a trained dementia caregiver. Ideally, we would love to hire a case manager who specializes in elder care services so we can expand clinical capacity, but again, we're hampered by lack of funding in this area.
Okay, thank you. My next question, as I said to the committee, I'm going to skip A at least for now, unless you advise me otherwise. To CSAC, on page 15, you describe reducing hospitalization through non-categorical case management. Could you tell us more what that means and how successful you're being in that?
I think that refers to the work of the adult stabilization team, which is a team that is providing case management and outreach to folks who are not otherwise based in CRT. And, I think their focus is to respond quickly around outreach stabilization supports in ways that could help prevent hospitalization. And they're really also eager to try to engage as proactively as possible once they hear of someone in the hospital to help, figure out what's going to be needed, what's going to help them to get out and do so on good footing and with some attention to, what they need to be back out in the community and a kind of more stable situation than maybe they went in. So I think they have been a really effective addition to the range of services that otherwise would be available to folks whose services are based in CRT.
Can you tell me a little bit more about what that looks like?
I think they try to be responsive as soon as someone comes to their attention. Referrals, could come internally from a clinician who's aware of the situation or from the emergency team. And then with the recent initiative that Dr. Jimerson was referring to, or maybe it was Rachel, but in terms of outreach to folks in the homeless community who, are struggling particularly with mental health challenges that might otherwise, lead them towards hospitalization. So, it's an outreach focus. It's trying to be low barrier, quick access, flexible with really a focus on not going in with any assumptions about what's needed, really trying to understand from the person they're responding to, like, what do you need? What do you need now? What can we help you with that's going to make a difference for you?
Okay. Because we're related on this, I'm going to skip down to D for people following along on the questions that we're asking. In the report on page 22, there was discussion of the emergency services program. And over several quarters, you had significant reductions in hospitalizations. And I'm wondering how you achieved that and how you sort of in that, I'm looking at 2018, how you managed to achieve such significant reductions in hospitalizations.
In terms of this particular table, we had to do a little research to kind of contextualize it. But I think it's referring to previous quarters, so there is one quarter that increases. I do think that is a stretch where through all of the things we've been talking about, we've saw some trending downward of hospitalization, between the outreach of the stabilization team, the open dialogue efforts, the really strong continuing availability of the cottage crisis bed program, which both diverts hospitalization and shortens hospitalization. All of the outreach, we try to respond quickly and make contact with hospitals and figure out, and with the people there to figure out like what's going to be useful next, and team as actively as we can. So I'd like to think that those efforts are what you're seeing in this chart. I also think that this is an important thing to keep measuring and to find better ways of measuring. We're kind of reliant on a by-hand count of hospitalizations now, and we want to have that become more of a kind of automatic thing. And I'd also really like to make the distinction between voluntary and involuntary and track our data in both of those. Yeah.
I guess my question would be, do you
Kate?
think this, yeah.
Hi, Kate and Zizek. I don't mean to interject. I think we need to prioritize the very critical questions at the end. If it's okay with you, Kate, let's move along to Malika and then Ward.
Sure. Yep. Thank you.
Thank you.
This is Malika. I had to step out just very briefly. Did you all already talk about peer support?
Not specifically. I think we've made some passing reference.
Great. Okay. Great. Would you just give us an overview of where the agency is at in regard to peer support services at this point in time?
Sure. So currently, we have people who identify their lived history as part of their role as, we have people with life experience who, are in identified roles as peer helpers, and then others where it's not expressly part of the definition of their job. Those who are in the kind of description of the role as with peer in the job description are working at Evergreen House and the center at 17 Court Street. So these are kind of wellness, recovery-oriented programs with mixtures of groups and activities going on there. And then with our Community Bridges project, which is an effort to really try to find ways for people to reconnect with their community around them and find, what would be, where do they want to get involved in something that they haven't been involved in, or build on a sense of community in their own life. And then, going forward, I think it's anywhere we can build more, we want to do that, and some of it is just, seeing who's interested in working in a peer role and kind of where that best match would be in any part of our service system. One idea we've been looking at more is with our residential programs. I think we'd also like to have more peer outreach capacity in terms of community outreach. And then certainly with the Open Dialogue project, having peer participation there in any way and to the extent possible is also something we want to keep building on.
Great, thank you. I think I can pass it over to Ward.
Hi, thank you. Yeah, I'm on. So what's your agency's current efforts around suicide prevention?
So we have someone doing the trainer training program in the You Matter training. So that's one direction. I think otherwise, a lot of our focus is on low barrier engagement, just trying to make it easy for people to connect and really try to pay attention to what gets in the way of people connecting with services and supports, and trying to really, focus on that. I think also the strength of the emergency team availability is a plus. We were working on some community engagement, community dialogue projects that got impacted by COVID. So those, we were starting to form some multi-stakeholder planning forums to really look at a mixture of issues, really as a kind of alternative to the mental health first aid model with a goal to engage community awareness more from a normalizing continuum approach as opposed to a kind of illness paradigm approach. So that was something we were starting to try to get going, and then certainly trying to have communications around suicide would be part of that project.
All right. So the other two of the other questions I had, I think, were clearly redundant to what we had before. Had one relative to results on SurveyMonkey, and there were questions about discrepancies between staff and supervisors' results. And
can you speak to specifically what those were? I couldn't find that reference.
Yeah. Okay. I think we can move on from here if we want.
All right. Thank you, Ward, and everybody. Thanks, CSAC. This is Marla. I'll be wrapping up the questions, prioritizing them, of course. I'd like to combine a couple of questions. Number 25 on client employment. Typically across the state, CRT employment is pretty low. What is the current data at CSAC of CRT part-time or full-time? I guess it would be part-time if they're getting Social Security, but what's your data on CRT employment?
So, I think historically we've done well with this and are usually in the kind of top three when there's statewide reports done, but there hasn't been that kind of data for a while, and certainly COVID is a factor. So I asked for just a kind of a quick hand count from our employment team, and really, it's remarkable to me that they're currently working with 27 CRT clients who are employed, and almost everybody that had been employed pre-COVID is now back at work, which I hadn't anticipated that finding. So I don't have an overall average right at this moment because we'd have to poll all the case managers to get a full picture of everyone who isn't necessarily working with the employment team, but that was certainly an encouraging finding at a time where I thought maybe.
Sure, great. Well, congratulations for being in the top 3 out of the DAs for that. I'm going to also combine staff support and morale questions combined with the trainings question. Currently, like today, what percentage of your staff combined would you say would be feeling very positive about CSAC, the staff?
This is Rachel Cummings. I make sure to get out in front of staff, whether I'm going to staff meetings or making individual one-on-one in-person Zoom or walking outdoor meetings available to staff. And it's been a consistent part of my practice as executive director since I got here. I would say before the email I sent out today, staff morale was fairly good. But I did just send out an email saying because of budget constraints, we will and no funding, no increases in funding from the legislature, that we are not able to provide cost of living increases to staff, and that our health insurance costs will most likely go up, resulting in the potential that staff might actually earn less this year than they did last year. So I think that is going to be impacting staff morale, and we're gearing ourselves up for how to, wade into that and address it and support staff. It was a tough message, and it adds on to providing services and being employed during a very uncertain time because of COVID.
Yes, Executive Director Rachel, that is a tough message. Just a tangential question. Is CSAC aware of any of the state of Vermont's hazard pay benefits for those working in person?
Yes, we paid. We received hazard pay from both Dale and DMH to pay out to staff. It was for a limited time, and it included a limited pool of people. We paid that out to staff, through that time frame, and so we are aware of it. Yes.
Great. And final question, are your trainings primarily virtual or remote now, meeting remotely?
I would say it's a combination. We've had a few where they've been in person. I know Sandy has held some, not necessarily trainings, but meetings with his folks outdoors when possible. We're trying to get back to more in-office, in-person sort of engagement, which includes trainings when it's possible, when we can distance, and when it's safe. So it's a combo.
Right, safety being number one, of course. And finally, if you could really quickly talk about outcomes for CSAC.
Can you be a little more specific?
Pertaining for staff and clients in terms of, are the collective amounts of services providing better quality of life for the people involved?
Hey, Sandy, I'm going to throw that one to you.
Sure. Yeah, no, I mean, it's a work in progress. I think I've seen a lot of false starts around outcome measures not, being labor intensive and not necessarily giving us useful data. I'm hopeful actually about the ANSA in terms of being something that, touches on a number of important domains and just would give us some indicators like, is this, is someone feeling less isolated as a result of our efforts? Are these different areas in, different domains in the ANSA, are we seeing movement in the right direction? So I'm hopeful about that. And otherwise, it's been difficult other than just checking in through surveys in any way we can and getting feedback. It's hard to find other indicators that are meaningful. Yeah.
So, thank you. So just to be transparent, some of the members of the committee have some diverging feelings about ANSA, feeling it might be just mimicking the GAF, the Global Assessment of Functioning. But how about for our last 5 minutes, CSAC and SPSC, how about we ask CSAC, what the meeting today was like, and just kind of wrap up in an open-ended manner for the last 5 minutes.
Mm-hmm.
Well,
So
Sandy,
first of all, we thank you for your answers and being as thorough as you possibly can be. So thank you for joining us today.
and this is Sandy. I'm just really impressed with the thorough and thoughtful questions you guys are asking, and so just appreciate the work and thought you're putting into this process.
Thank you. Did you have any questions for the SPSC CSAC?
I did want to just quickly add on to the grievance questions that you had asked, and Andrew, our new compliance and quality officer, just couldn't make the sound work, but wanted to stress that his role as a grievance coordinator, allows clients to be able to confidentially express and file any grievance they want, and that he can carry out that investigation with as much confidentiality as possible to prevent any retaliation. So, he can report directly to the board. He has his, while he reports to me, he has that avenue to, have that separation and report directly to the board and ensure that, clients' confidences are held closely and that they have multiple avenues to report grievances. So I wanted to just...
Right, and also Rachel and CSAC, it is a rule of DMH that if a client makes a grievance or an appeal, that retaliation would be very unethical, as one of your staff members stated.
Yes, of course. We realize that fully and support that fully. Absolutely.
Yes, thanks. Thanks so much.
Dr. Jimerson, I just wanted to comment on the conversation today. I really appreciate the diversity of your group in asking questions, and I think it's so helpful to have individuals participating who have also received services, and that really, I think, informs a better understanding of how we all move forward.
And this is Rachel. This is my first go at it as a new executive director, and I'm just very impressed with the process and the thought that went into it. So thank you for this.
Thank you. We're pleased. You're welcome. Any other members, any final thoughts before we wrap up this interview process?
Just want to thank folks from CSAC for your tolerance and flexibility of using this platform where we can't really see each other. It's a little less connected than it usually is. So, I just want to acknowledge that and also express my appreciation.
Thank you.
And also good safety and health blessings to everybody with the pandemic. Stay safe, be well.
Thank you.
Thank you. You too, everybody.
I must say I'm working part-time per diem from home for the Vermont Support Line. And I love working at home. I'm a germaphobe, so I don't like being in close contact because of the pandemic. So that's just something to consider about trainings or meetings for certain types of personalities.
Thank you.
A lot of respect needs to be developed around those issues. We agree.
Yes, thank you. All right, anybody else from the SPSC or CSAC or DMH? All right, well, thank you so very much. And we wish you a wonderful rest of the afternoon and evening. And thank you once again.
Thank you, everybody. Have a good day.
Thank you.
You too. Bye-bye. All right, so Eva and DMH, so CSAC has left, is that correct?
That is correct, yes.
Okay, great. So we're moving along 2:30 to 2:45 p.m. Drafting letter of recommendation to the commissioner regarding CSAC redesignation. So we do our usual. Does
everybody have in front of them or online or their phones the redesignation voting numbers, and we can discuss and reflect on that interview plus all of the documents. I believe they were only negative a no in 2 areas, governance and system of care.
I just need to say that I'm going to abstain from this section.
All right, thanks, Thelma. This is Marla. I did feel the question about somebody going off psych meds or not wanting to be on psych meds at all was not really clearly addressed. Otherwise, I felt they were professional and wanted to give, like I said before, very, very, very thorough responses to our respective questions.
Yeah, I feel like, as is usually the case, it makes sense to me, and I can make this as a motion if people want me to recommend redesignation with minor deficiencies, and then work on crafting the letter where we can be more meaningful in our feedback than that.
Malika has motioned a redesignation with minor deficiencies. Is there a second?
I'll second. This is Vicki.
Okay, Vicki is seconded. All those in favor, please say aye.
Aye.
Aye. Aye. Anyone opposed? Thelma has an abstention. Anyone else abstaining? Okay, so we have a quorum, correct, Eva?
You do, correct.
I believe we have a quorum and that motion has passed. So they will get a redesignation of full redesignation with minor deficiencies. And as Malika had politely mentioned, we will now work on crafting the letter. So I think it would be good for members to bring out some positive reinforcements, maybe also in the letter, positive psychology about, their executive leadership, their medical director, the adult director, and so forth, showing up. I felt they were polite and intelligent. They expressed appreciation at the end. They are addressing issues of violence at their residential, and I felt that they were well informed ahead of time about the questions that we had prepared, that the members had prepared.
I would love something in the letter about, I don't know, something about peer support. Like, they have peer support in multiple programs, and that's awesome. And we'd love to see in the future, the representation of peer support in leadership, and also a unified peer support team with shared, a shared team across programs, as those are best practices.
Yes, and also, go ahead.
Oh, I'm sorry. I just wanted to also say, I noticed, possibly, might just be me, but I think I noticed possibly a blurring of the line between understanding the difference between a peer support worker and a staff member who has had psychiatric experiences. And I just that's a pretty important distinction, I think, for DAs to make, and we might want to just mention something to that effect.
I think that's an excellent point, Vicki.
Vicki, do you think that they made that? I heard them make a distinction, like they mentioned peer non-peer staff with lived experience in the question about peer support roles, but they did in the end sort of differentiate, which is better than sometimes happens. Do you feel like they did or did not sort of address the difference enough there?
I feel like they definitely did not do a bad job, but it seemed a little bit fuzzy.
I feel like they emphasized wanting more peer outreach at hospitals and quote unquote in the community. I think an overall problem across all of the DAs is when quote unquote peers are hired, it's certainly not at the salaries of other staff that do not identify as having lived experience.
I think that's a really important point.
I don't think that happens here, but I can't guarantee that. I know that I make and the other person that's a peer, we get paid more than some other frontline staff.
All right. Well, thanks, Salma.
On the topic of peer support, I would like to also add to encourage them to expand their use of peers in the emergency department environment.
Yep, I agree. We were having that discussion before COVID hit. So I would really encourage them to keep doing that.
Yeah. On the positive, I'd like one thing on the positive side that I feel came out also in scanning through the material. It feels like they're doing a better than average job in terms of training. For example, 76% of staff are rated their approach to training is excellent or good. And also he talked about, looking at best practices across the globe, and even gave some, good examples of like reducing coercion models in Italy. So I think I'd like to give them kudos for being comprehensive and broad thinking in terms of training.
I would also like to, I can add this too. The agency's commitment to open dialogue and looking to other places for inspiration and support has been really helpful.
Yeah.
Yes, there were a number of references to international studies, which I found was impressive.
Yeah. Yeah, I think open dialogue is a strength. Again, reviewing the material, that DMH gave them kudos for excellence in that area. And I got the sense that's the case.
Selma, so they call it open dialogue and not collaborative network approach?
They call it either one.
Right, because open dialogue is copyrighted and very expensive to call it that.
Well, they've actually done all this stuff from going to Norway and all that stuff.
Oh, wow.
So I guess
all
I
right.
guess it's open dialogue.
This is Trish Singer, FYI on the Open Dialogue name. Open Dialogue also means certification through a particular trainer down in, I think, is it Holyoke, Mass, or it's Cunningham, and they have not done that. So they do call it collaborative network approach because it would be a copyright infringement to call it Open Dialogue, but it's based on the Open Dialogue evidence-based practices model.
Oops, I didn't know that.
Thank you.
Thanks, Trish. So we have 5 minutes to continue drafting the letter. Anything else?
This is Kate. I have to say that I didn't feel like the discussion about reducing hospitalizations was informative to me. Maybe other committee members got more out of that, but I didn't really understand. I didn't have a clear idea of how they were doing that, and I also didn't, maybe perhaps it was simply different clients that were, being addressed at that time. Maybe it's more a function of the population who they were dealing with rather than the approaches they were using. And I had a hard time deciding what I felt their answer was about that.
Yeah, I concur with you, Kate. I think it's to me it was a little ambiguous what they're doing, and I also felt the same about their approach and philosophy relating to medication and tapering off meds. So yeah. I would put both of those in the category of areas for improvement. I mean, they're not that they're doing poorly, but they should continue to focus on more progressive approaches to medication and reducing hospitalizations.
Yeah, I didn't know it was more a function of not enough time. I didn't know if it was a function of not enough time for them to really say more, but I really didn't. I didn't know if it was more a function of them being more effective, or they had different sorts of clients that maybe required less hospitalizations, or I just really didn't get clarity there.
I think one of the things that's helped with hospitalization, and I know a lot of DAs now have this too, but the crisis bed has made a big difference here.
Yeah. One thing I thought was positive in terms of two particular positions they mentioned were, one was the quality position that was recently filled, and it sounds like that person is going to continue to be doing some good things relative to feedback and grievance and appeals, and the other was the staff position for the elder community population. I'm really glad to hear that they have someone that's focused on that comprehensively.
Mm-hmm.
And also connecting to the community and entities, outside of mental health to coordinate and collaborate.
I think
Kate, I concur with your feeling. I think we had 28 questions, and there were very long answers to some of the earlier questions. So I think that's the reason.
Mm-hmm.
I'd like to give them kudos for opening the MyPad.
Yep.
Yes, definitely. We should definitely highlight that.
Mm-hmm.
And also kudos, it said in the report that the staff feel that the executive director is accessible and approachable.
I have one concern, and I don't know if CSAC is just on the same page as all other designated agencies, but I know places that I've worked in other states have had trainings on how to stay safe and handle, physically escalated situations, not necessarily, to stay safe yourself and to keep the client safe. I kind of got the impression that if anything escalates where there's any worry about any kind of physical harm, that their procedural response is to let the police handle it. I know that was problematic in hospitals, having staff or having police handle physically escalated situations rather than handling it from a mental health perspective and training people in having positions that include that. And I especially with what's coming out on the news of some of the outcomes, and especially in Montpelier, I've heard of outcomes where police respond to mental health calls and they're not responding from a mental health perspective. So I was just a little concerned that it seemed like sort of their go-to answer was just to get a police officer to deal with the situation.
Well, maybe because I'm inside. Well, I know that one of the things they take really seriously, though, is the CPI training and making sure that staff learn de-escalation techniques before they call the police.
Okay, that's helpful.
What if we asked them a question that wasn't a part of our questions? Would that be okay, Eva? In regards to Kristen Chandler and the Team 2 trainings, mental health working with police and training?
There's actually a Team 2 training coming up in October, I think.
Okay.
Yep.
All right. Well, okay.
So is there a follow-up question you'd like to ask?
Well, I don't really know if I mean, Selma abstained and she's got the inside point of view. Maybe we could just say, you know, I've been to a Team 2 training and know Kristen Chandler just that we recommend that police have as much mental health training and de-escalation training as possible.
That sounds to me like something that's a little bit out of their purview.
Okay, sure.
And honestly, I would prefer them to be focusing on ways to obviate the use of law enforcement, keep law enforcement out of situations, and focus on mental health and social working, and peer support.
Right, I agree with that too. I agree with that too. Sorry.
Yeah, I was just saying, being first responders in situations where there's not severe risk of harm, or law enforcement law issues, which I know is a very complicated situation to try to parse out.
Yeah, Dan, I appreciate that. That's kind of my view too, and I would just I'd feel a lot better if they had a explicit plan on how to reduce reliance on law enforcement, especially with established clients where they know the background in the situation, and kind of have trainings specific to that.
I liked exactly the way you articulated that, Vicki. If that could be put in the letter, I think I would support that.
Thank you.
All right, we are at 2:46 p.m. It's time for public comment. Do members and everybody, do we feel we have enough information for the letter?
Eva, did you capture? Do you feel like you captured what we were saying pretty well?
Yeah, I'm gonna send that out to everyone after this meeting.
Yeah.
The next day or two.
All right, thanks, Eva. Thank you.
I feel good about the feedback we've just been giving.
I feel good about the feedback. All right, it's time for public comment until 5 minutes to 3, please.
Can I ask a question of the public who's there? Can you give us impressions of how this meeting has been, particularly anybody who's a first time or hasn't been to many meetings? Like Zach, have you been to many of the meetings? Are you still with us, Zach?
Lynn is also there. Zach may be muted.
Yeah. Anybody else from public care to comment about?
And also they are there. A member of the public.
Well, I'll just pipe up and say that I'm going to reiterate what many said, both from CSAC and from this committee. But it was a pretty impressive session. I mean, I thought you all handled the evaluation incredibly well, and intelligent questions and excellent answers, and it was just really impressive.
Thank you. Thanks for that feedback.
I might add that in that we weren't piping up during that time. If there were a couple of areas that interested me, not so much as far as the evaluation goes, but just areas that I would have loved to have heard more about, was the elder focus, because I think that there is a severe lack of focus on mental health issues, and with regard to elders, I think it's way too easy for everybody to chalk it up to dementia or whatever else. But quite frankly, depression is depression, And and we could go on and list any other diagnoses, but I think that's an area that is certainly, I think all areas are underserved, but that to me is an area that's severely underserved. And I think that the committee has heard me pipe up before about my concern with regard to suicide. And I just, I think lots of people and organizations and are trying very hard to make a difference in people's lives and be able to reach out and connect with people in a way that is effective enough to have them decide not to take their life. But I don't think it's working that well. So it's just, again, so those are just the two areas that if I'd been given a free ticket for a little more chat on those areas, that would have been great.
This is Zach.
Ah,
Hello?
Zach, can you?
Hi, Zach.
Yes, this is Zach. I think the committee is doing quite well, and I continue to, I had a little bit of a concern about the overnight screener. There's only one, and this is common in a couple of the, or another DA, or was common when I was on the children's side of the committee, standing committee, because of the size of the county, I suppose, but it was kind of concerning because it cuts back on the ability to support, I think. So maybe they could, look at increasing the peer side of it a little bit. I don't know.
Great point, Zach.
But generally speaking, I think the committee meeting went well today.
That might be a good point.
Good point, Zach. Thank you, Lynn. All of those are good points.
Thank you.
Can I just ask which Zach we're listening to?
Zach Hughes.
Well, that's a grand thing.
Not that the other Zach wouldn't be great to listen to as well.
We love the other Zachs too, but
Okay, I don't know how many Zachs we got going on.
It's my brother, my other brother, Daryl.
That restaurant where they filmed the Newhart show is in Middlebury.
Yes. Cool.
The outside of it, at least. The inside was a Hollywood set.
Oh, okay.
Waybury Inn.
Yes.
Well, maybe you could put a note down bottom somewhere.
Marla, I have a question to go back to the DMH update, whenever it's appropriate. I don't want to short circuit public comment if there's more, and we do have to.
Sure.
Can I ask the question now?
Of course.
Yeah, it was unclear to me how we left the update and the response to the letter it wasn't clear what our next steps were, what we're expecting from Sarah or DMH relative to that letter and the response, which not everybody received.
Eva resent the letter, so I'm going to need some time in the next 2 days to read that thoroughly. I think we can keep up our email communication or phone communication if people wish. I think until everybody's read the letter, it needs to be put on hold for at least a couple of days or a day.
Well, yeah, right. But also next meeting, I was hoping that we could revisit it after we all have had a chance to review it and maybe had some communication via email.
Right, absolutely. So that kind of goes to the October draft agenda, putting that on the agenda, Dan.
Right, yep.
And also on the October agenda, please the more membership update. There are more people interested in the subcommittee process update, and also the 3 members from one organization discussion.
Yeah, so for the next meeting, grievance and appeals, I think, was one of the big topics that we intended to cover, right?
Mm-hmm.
Correct.
And I think we agreed that we would try to pull together questions relating to that, so we to be more helpful to DMH in terms of what our issues and concerns are.
Yes, also the site visit and the hiring of key management discussion. And also on a future agenda, I would really love to hear more about Ward's work with therapy dogs. I worked with Therapy Dog Vermont in the past, and if it's not on October, it would be great to have it sometime soon. Possibly also an update from Allison Kay on suicide, or in the near future, Brian Smith on housing. The other thing is Sarah requested a priorities list from the SPSC. That could be a top 10 or top 20 list that we via email could work on.
Yeah, thanks, Marla. I think because we have so much of our own business that we've deferred for months, it would make sense to me to hold off on inviting anyone else to our meetings for a while, just so we can sort of play a little catch up, and also give some important conversations like our response to the DMH's response to our letter, the time that we need to really take care of that fully.
Yeah, Malika members, would it be useful to share the Planning Council top 20 list with you, or top 10 list with you?
That's an area that I'm particularly interested in. This is Kate. Yeah, I've highlighted that as something that Commissioner Squirrel mentioned that I feels like really help us work more efficiently as a committee. And anything that moves us toward being able to do that, I would be all in favor of.
Great. I will get that list out by 11 p.m. tonight. I'm doing third shift work this week, but I'll get it out by 11 p.m. tonight, okay?
Perfect. Thanks.
I wanted to make a quick suggestion, if I could. So we have a list of things that the committee has requested, kind of an open action items list. I'd like to propose that we set aside maybe 5 minutes each meeting to just kind of go over where we stand with requests that the committee has made.
That makes sense to me.
Mm-hmm.
Great, thank you.
May I ask a quick question?
Yes.
Sure.
I got called out on an emergency call for about 5 minutes while Sarah was doing was speaking earlier, and I'm wondering, did she touch on COVID at all? Was there any discussion today at this meeting about the pandemic?
There was not. This is
the only reason.
There's going to be a more robust update next month, and Fox, the deputy commissioner, is planning on being here for that. But today's update was solely focused on the response to the letter, which was not about COVID this time.
Yeah. Okay, that's what I thought. I just wanted to make sure. I remain concerned that my cat is getting in on. Sorry, assistant. So I remain concerned that people who live with mental health issues or psychiatric disabilities may not be being provided an equal opportunity for safety. In other words, assumptions that they can't wear masks, and I think that there are facilities and so forth that are viewing this with kind of a herd mentality. So that's why I bring it up.
I know Governor Scott last week or the week before said there were free masks through the governor's office.
This isn't about accessing masks. I mean, it's easy to access masks at this point. This is about group settings where the people who are administering are deciding that no one has the capacity to understand enough to take on the safety measures of masking and distancing. And it may be true that some, maybe even most in some settings don't. But that doesn't mean that if there's even one individual who has the capacity to understand those safety measures, that they shouldn't be given the opportunity with accommodations to understand it and to participate in what is considered the most safe circumstance for any of us. So because you're in a facility or a group, it doesn't mean that you have to go down with the rest, you know?
Thank you for those comments. I agree, and also this connects to one task that I think needs to be on our item for our next agenda is the committee thinking about the public comment that we got last month from someone who had stayed at the retreat in a double room. You know, all the issues that came up there we have not yet processed or thought about what that might mean for us in terms of recommendations or questions. I do have to get off. We're over time. I'm sorry I can't wait for the end of the meeting, but I have to be somewhere else. But I just wanted to flag that so it doesn't get lost.
Thank you. Important point. We are at 3:02 p.m. Does everybody feel comfortable if we adjourn soon?
Could Eva just summarize the agenda for next week, next month? I'm not clear what
I see here is opening business 12 to 12:10 with things that weren't addressed this meeting, including minutes and the other items from this agenda. 12:30 to 1 o'clock, DMH update from Fox. It sounds like no grievance and appeals discussion because it sounds like you want more time for SPSC business. A break, and then SPSC business, which includes the response to the response letter from the commissioner, a recurring item of list of items requested by DMH for discussion. The committee thinking about the public comment from August, potentially a top 10 or 20 priority list, working with therapy dogs if there's time, followed by public comment and future agendas.
Okay, thank you.
Mm-hmm.
Thanks, Eva. All right, Malika has to be somewhere. My partner just walked in, so would anyone like to make a motion to adjourn, please?
I make a motion to adjourn.
Selma has motion to adjourn. Is there a second?
Second.
Who seconded?
Kate.
Kate.
Hi, Kate seconded. All those in favor, please say aye.
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 Aye. Any opposed? Any abstentions? All right, we're adjourned at 3.